Guys, today we're going to talk about sensory alterations as far as assessment and what we should be doing as nurses in order to understand deficits, overload, and deprivation. Our learning objectives are going to be to differentiate the different types of sensory, whether it comes to deficits, overload, deprivation, look at conditions that can interfere with that process, discuss factors that may affect it, and then we're going to look at the testing that can diagnose what's causing the problem and nursing interventions to facilitate or maintain that sensory perception. So, just a basic introduction is that people process sensory information through the central nervous system. Everything is sent through the spinal cord into the brain for interpretation and reaction. And then any alteration in this process will impact a patient's well being. If you're unable to see, then you're unable to really navigate your surroundings very well. If you're unable to hear, then you might not be alerted to an emergency. So, we're going to work on ways to create a situation where all of our patients are safe and able to react to emergent situations appropriately. So, a sensory deficit is where you're just not getting that expected function in one of the five senses. An example is hearing loss, vision loss, any tactile loss. If you have a stroke and you have a hemiplegia, you may not have feeling in one of your hands. And it's really important that we understand where we've got those deficits and how to manage them. Sensory deprivation is things like you have no ability to process the stimulation to that sense. So, a blindness would be a sensory deprivation. If we're blindfolding a patient, if we are taking away their ability to hear by putting in earplugs, we're not going to be doing this in general, but these are different ways that senses can be deprived. There are sensory deprivation tanks that people go in that are actually potentially useful for their mental health. So, sensory deprivation is not always a bad thing, but we need to look at it and determine whether it's good for the patient in that moment. Sensory overload, I'm sure we've all seen an autistic child who is dealing with sensory overload where they just cannot manage all the information that's coming into their little bodies at the same time and just really get overwhelmed. It's very common with ADHD and a bunch of other issues too, and it can be very common in the hospital because you have lights that are going on and off. You've got call bells dinging. You've got alarms ringing. It's very easy, even as nurses, to get overloaded. So we've got to find ways that we can process this information meaningfully and decrease the overstimulation. And then sensory processing disorders are just those difficulties interpreting, responding to sensory stimuli, even though they can detect it. So that is your autistic child who's getting all this visual and verbal stimulation, but they don't know how to process it. So it's really important that we understand all these different types of sensory alterations and how to manage them in order to help a patient's better. The cranial nerves are some of the most important sensory pathways. They're very difficult to memorize what they are. There's 12 of them, and they control most of the sensory and function of the head and the neck down to the shoulders, where you've got that shoulder shrug that you're checking for when the cranial nerves. Any dysfunction in a sensory nerve can really lead to alterations and impact a patient's well-being. So for vision, the we all know the anatomy. Light goes into the eye, passes through the lens. The lens puts it into the optic nerve, which goes to the brain. Any refractive errors like myopia, hyperopia, and astigmatism. Myopia is that farsightedness where you just really cannot see far at all. Hyperopia is you really can't see near, and then that astigmatism is what causes the halos around the lights if you're looking at them. And presbyopia is age-related vision loss. Those are the people that have had great vision their whole life and now suddenly they need reading glasses. Those are the most common causes of visual deficits. And then, as some of you may be aware, the eye is pretty hollow, so there's what's called the vitreous humor inside the eye. It is a jelly-like substance that's going to help with concentrating that light onto the optic nerve. So any deficit in any part of that eye structure can cause visual issues. Cataracts are that clouding of the eye lens. They cause blurry or hazy vision. They're usually an age-related process, and when they get bad enough, you can see them. Diabetic retinopathy is damage in the retinal blood vessels. The damage from diabetes starts with the smallest vessels first. So the eyes are one of the first places you may notice damage from diabetes. They can get spots in their vision, they can get floaters, blurred vision, and they can potentially go blind if they're not followed closely by a um, ophthalmologist and getting in good glycemic control. Glaucoma is an increase in pressure in the eye that compresses the optic nerve, which causes irreversible loss of the vision to the sides. They'll still have that central vision, but they'll have no vision in their periphery. And then macular degeneration is the polar opposite. It's a degeneration of the macula, which is a disc in the back of the eye next to the optic disc. It leads to loss of that central vision, and it happens a lot in older adults. There are a couple types of it, but for the purposes of right now, I just want you to understand that that is the loss of the central vision in older adults. There are treatments for every single one of these if we are catching them early enough. So diagnostic testing. We're going to do that visual acuity testing. That tests cranial nerve number 2. We are looking at the Snellen chart and the tumbling E chart. That's the one where the E's are kind of all over the place. We're going to assess their distant and near vision. If somebody's vision is 20/20, it means that they can see at 20 feet what everybody else can see at 20 feet. That number on top is never going to change. It is going to be 20 feet. We are going to get the patient 20 feet from that chart, and we're going to measure how far down the chart they can see. Patients who can see 20/70 can see at 20 feet what other people can see at 70 feet. So it means that their vision is slightly declining. There's the slit lamp examination. They're going to look at the eye a little bit closer with a really bright light, and it magnifies so that they can see the structures and see cataracts and other eye conditions. Fluorescein, it's gonna be an injectable dye, so they can look at those diabetic retinopathy in the back of the eye and really look at those blood vessels closely. The Amsler grid test detects central vision distortion. They're looking for macular degeneration. And then intraocular pressure measurement. That's that puff of air that you get when you go to the eye doctor. It's looking to see if you have too much pressure in your eye, and it is the key to diagnosing glaucoma. So now we'll move on to hearing. Um, Sound waves go into the ear, they vibrate the eardrum, and then they go through the ossicles. Those are those tiny little bones inside the ear, the incus, the stapes, and the malleolus. Then it goes through the cochlea where there is, or cochlea, where there is tiny little villi that are vibrating in order to get that sensory information through to the um, auditory nerve to go right into the ear, or right through the ear into the brain. Then the brain is going to take all that information and it's going to translate it. Hearing loss comes from infection, injury, loud noises, aging. Often they'll have tinnitus, which is that ringing in the ear. And you can have hearing loss that's simply because you have way too much cerumen or earwax impacting that ear canal, and it makes it so that the vibrations are unable to get through. Types of hearing loss. We've got that sensory neural. That's the problem in the inner ear or auditory nerve. Those villi break down. They're not able to vibrate as much. You've got just auditory nerve damage that could be from a congenital factor, like you're deaf from birth. It's a very common cause of deafness. Um, it can also be due to noise exposure. Listening to music too loudly on headphones can cause sensory neural hearing loss. Age can cause sensory neural hearing loss. This is when you get the elderly people that are like, I'm not having trouble hearing, but they're answering questions inappropriately. So we need to make sure that if somebody's not answering your questions appropriately, we're evaluating to see if they're even hearing us correctly. Conductive hearing loss is that blockage from trauma, infection, that cerumen I was just mentioning, or otosclerosis, which is just a stiffening of the ear. Mixed hearing loss, you can have both at the same time. A lot of people who have hearing aids will end up having impacted cerumen because it has nowhere to go and it's getting pushed back by that hearing aid. This is why we tell people do not use Q-tips to clean your ears. If you're using Q-tips, you are pushing that earwax back and making it get. And then ototoxicity are those medications that can damage the cochlea or the vestibule, and they can cause those inner ear issues, causing hearing loss or even balance issues if there's cochlear damage. Medications that are considered ototoxic are things like NSAIDs. Ibuprofen can be ototoxic. Medications like vancomycin can be ototoxic. So we're really watching these medications closely to make sure that when we're delivering medication, we are not causing damage. So hearing is one of the major things you need to assess when patients are taking medications. And it's important to recognize that there are medications that can cause hearing loss. The RIN test determines if it's bone or air conduction. That's the one where you're going to hit your tuning fork, you're going to put it behind the ear, touching that mastoid process, and have the patient tell you when they can no longer hear. Then you're going to pull the tuning fork away from that part of the ear and you're going to put it directly in front of the ear canal. You're not going to touch them anymore, but air conduction should always be greater than bone conduction. Um, Pure tone audiometry. This is what you did in elementary school when they'd have you raise your hand on the side you could hear the noise on. The bone oscillator test that assesses the ossicles. Again, it goes on that mastoid process. Auditory brainstem response tests that measures your brain's electrical activity. That's going to be more done with audiometry. And then the otoacoustic emissions test, that's another one that's done by audiometry. And they're going to look at the inner ear response to the sound waves and they're going to monitor any echoes that are occurring in there. So it's not important to really know most of these tests. The only ones that nursing really will do is the RIN test and the pure tone audiometry test if you're a school nurse or in a pediatric office. Excuse me. The rest of them you're going to be referring over to an audiometrist. Speech alterations, we've got that aphasia. It is a disorder that affects the ability to either speak or understand speech in written language. It's often caused by brain damage in certain areas of the brain, usually in the frontal lobe. Broca's aphasia is that expressive aphasia. They can understand everything you're saying, but they struggle to get the sentences out. They are going to be very frustrated because they know exactly what they want to say to you, but they cannot get the speech to form. They'll use short, meaningful phrases instead of more long, flowy, descriptive words. Comprehensive aphasia is that Wernicke's aphasia. You speak in meaningless, long sentences that don't seem to make sense, and they're not usually aware that people don't understand them because they know what they're trying to say. So, again, they're going to be very frustrated. This is one that is very easy to confuse with a psychiatric disorder because it comes across like what is considered a flight of ideas, where it's just a bunch of meaningless speech rambling together. So it's important to determine, did this patient have a stroke or some sort of issue that caused them to speak in these meaningless long sentences? We don't want to or have somebody get a diagnosis of a mental illness when it's really just the residual issue from a stroke. And then global aphasia is a severe impairment. They cannot speak at all. They cannot understand speech at all. These people very commonly will get diagnosed with dementia because they're not responding to anything at all. It's not because they don't want to, it's because they physically can't. And it's important to look for other cues that may indicate dementia, like a patient who's walking around on the floor and they go to grab their keys, but they don't know where their keys are, or they're forgetting how to eat. Patients with global aphasia will not be forgetting how to do things. They will simply just be unable to communicate. Sensation disorders. Touch receptors in your skin are sending signals all the time, even though you are not actually feeling it. You may not notice that you are feeling that you are touching the chair underneath you until you're thinking about it. But at all times, your body is sending signals to the brain indicating what it is doing. It can provide that heat, cold, pain, pressure. The disorders range from the inability to detect touch So patients with diabetes will very frequently get that neuropathy. This is why we do monofilament testing on the bottom of their feet to see what they can detect. Um, some may have extreme sensitivity. Some may have significant pain from something that's not threatening, like to what you or I may be no big deal. They're in excruciating pain, and it's important that with pain, we always take the patient seriously. What they say they are feeling is what they feel. We're not going to argue with them. We're not going to decline giving them ordered pain medications because we don't feel they're having pain. If the patient states it, they're having it. Causes of alterations, that peripheral neuropathy I mentioned, usually is caused by diabetes, but it can be caused by other issues. Um, it can cause, it's the damage of those peripheral nerves, affects the hands and feet, and causes numbness, tingling, or pain. They may have severe pain that has no known reason other than that nerve damage. Diabetic neuropathy is that nerve damage because their blood glucose is super high, and triglycerides, which are one of the cholesterols, are actually considered a sugar based. This is one where this is the reason we want patients fasting. If they are not fasting, their triglyceride levels can be through the roof. A patient with severely high triglyceride levels gets put at higher risk for pancreatitis. So there's many, many reasons, including that neuropathy, to get those blood sugars under control. Idiopathic neuropathy, we don't know why it's damaged, it just is. And then any spinal cord injury can lead to partial or complete loss of touch sensation below the injury point. They may feel everything, they may feel nothing. So we need to take each patient as they are and treat the patient, not what we think the disease process is going to be. Taste and smell go together. If you can't taste, you can't, or if you can't smell, you generally can't taste. That's why I advise little kids if they're having to eat their vegetables and they really don't want to plug their noses. They won't taste it as well. They're very closely linked senses. They protect us from harm. They stimulate appetite. They differentiate between flavor and odor, and they send messages to the brain so we know what it is. Phantom taste perception is that just you suddenly have a foul taste, but there's nothing in your mouth. Um, Hypogeusia and ageusia are that increased or decreased or complete inability to taste. That was a common thing that was occurring during the COVID epidemic. Patients were developing the inability to taste anything. Dysgeusia is that persistent salty, rancid, or metallic taste in your mouth. Anosmia or hyposmia are the inability or reduction of that ability to smell. And then parosmia and phantosmia are those altered odor perceptions where something that should smell really nice, like flowers, smell disgusting, or they might have no smell that is around them, but they're smelling it. Um, Think of patients who smell something like burnt popcorn, which can indicate something is going on inside the body. So if somebody smells something and it's not the same thing you smell, it's important to keep our minds open and try to think of what could be causing these issues. So, as we age, our senses become less acute. We need more input to trigger those responses. This does not mean that the responses are lessened. It just means that we're not responding as quickly. This is why the elderly may get burned more significantly than a younger person because they're not responding as quickly to that sensation of burning. So they are getting more of a burn before their hand pulls back. So they will have more severe pain in the long run because they're having a more severe injury. Hearing loss. Hearing loss in the elderly is going to start with a difficulty with high frequency sounds, distinguishing sounds from each other, and they're going to also have that increased cerumen impaction. That's just a part of aging. It is important when we're dealing with hearing loss that we are not yelling at our patients. We want to deepen our voices, especially women. Women and young children become very difficult for the elderly to hear, so it's important to slow our speech, enunciate appropriately, and speak in lower tones. Vision changes. There's that presbyopia, which is that decreased visual acuity. Corneas are less sensitive, pupils get smaller, the eye muscles weaken, and they have more difficulty differentiating colors. These are all normal parts of aging. Taste and smell will decline. Um, this is why a lot of elderly patients will want to eat a lot more sweets because they have less of a sense of taste for sour, salty, and bitter, and they can really struggle to identify any odors. So they're going to be at higher risk for malnutrition. Remember, malnutrition does not mean that the patient is not getting enough food necessarily. It means they're not getting the right nutrients. Reduced touch. They've got that decreased peripheral circulation. They're going to be decreased in their sensitivity to being able to touch things and feel pain. So they will still have significant pain. They are just going to have a reduced reaction to it initially. Medications, ototoxic medications. 600 drugs can cause temporary or permanent hearing damage. You do not have to remember all of them, but when a patient's on a medication you're unfamiliar with, look it up. Make sure you know if it's going to cause damage to an organ or a hearing. Just really important that if we have something unfamiliar, we're looking it up and not just assuming we know. Taste alterations. Medications cause bitter and metallic tastes in the mouth. They can alter that overall taste perception. So it's important we have an idea. If we don't recognize a medication, we're looking it up to see if it causes any of those issues. If a patient's reporting those issues, we're talking to the doctor, trying to determine ways to help them get that good nutrition. And then most medications will cause dry mouth. You can get ulcerations, you can get altered taste, it can cause pain, it can cause patients to not want to eat because their mouth is so dry. It can cause overhydration in certain patients who have certain diseases like chronic kidney disease and congestive heart failure because they're trying to keep that mouth moist. It's important that if we know a medication is going to cause dry mouth, we think of ways to prevent it. Lemon glycerin swabs, as I have said a million times, are not appropriate for patients with dry mouth. Lemon glycerin is a drying agent. So if we are using mouth swabs, we are using the green plain swabs only, and we can dip those in something like biotin to really help with stimulating that saliva production. Dementia versus delirium. The easiest way to remember dementia versus delirium is dementia does not come on suddenly. If you have a patient who yesterday they were sharp as a tack and today they are confused, they do not have dementia. They have delirium, and we need to look at what's causing it. Delirium is generally reversible if we figure out what is causing it. The most common cause of delirium is an infection followed by something like overstimulation. Dementia is chronic and irreversible, and it has a slow onset. So make sure we're recognizing, is this brand new for this patient? For vision, starting when they're young, educating on that eye protection, wear UV sunglasses, wear safety goggles when doing anything that's going to throw up a piece of metal or a piece of wood. Get your regular eye exams. One thing that is not commonly taught to people, especially homeowners, is that if you are turning on a breaker because it tripped in your home, do not look while you do it. If a breaker throws an arc, it's going to be very bright and it will cause immediate blindness. Make sure you find the breaker you need to turn and turn your head away. Make sure corrective lenses are available and used by patients. Make sure there's enough lighting. Offer a large print if it's more beneficial for the patient. If the patient has a severe visual deficit, make sure we're announcing that we're coming in the room. Hi, Mrs. Jones. This is Susan, your nurse. I'm just here to do this with you. When you first bring them in the room, tell them the layout of the room. When you bring them their meal, tell them in a clockwise pattern what's on the tray so they can feel more independent. And make sure that we're keeping the room with the same layout. We're not changing things up on them. We're making sure it stays consistent. And if the patient is able to read Braille materials, we get them to them. Hearing. Again, we're starting young. Ear protection, reasonable music volumes, using headphones that have ear protection. There are a lot of headphones available on the market now that can be set, especially for children, to not be able to turn them up to a volume that's going to impact hearing. Um, Ear protection should be used by anyone who's shooting a weapon, unless it's a police officer and they're, unable to wear it in the field because they never know when they're going to be shooting a weapon. But if you're going to the gun range, use the ear protection. If you're going to be going to a parade and there's going to be a lot of fire trucks hitting those horns, maybe have some ear protection. Any demolition derbies, tractor pulls, anything that's going to be really loud, we're going to want to have that ear protection. Make sure we're looking at people while we're speaking to them. We have adequate lighting, the patient can see our face, and we've got minimal background noise so that they can see what we're doing and look for nonverbal cues. Make sure patients have their hearing aids available, they're working. Um, there's some great over-the-counter options for patients who have mild to moderate loss because hearing aids are incredibly expensive, and unfortunately, a lot of insurance plans will not cover them. If the patient is deaf, we're using our sign language interpreters, providing written materials, but it's really important to remember that if someone was born deaf and they utilize ASL, English may not be their first language. ASL syntax is not the same as English syntax, just like Spanish or Nepali or Chinese or um, any other languages around the world, their syntax is not going to necessarily be the same as English. So it's important that if we're providing written materials to people, they are at a sixth grade level and they are materials that can be easily understood even if the syntax is different. Some patients with deafness may be interested in a cochlear implant. Some patients with deafness may have no desire to have a cochlear implant because it would be like taking a person who has spoken Spanish their whole life and telling them in their Spanish speaking community that they have to speak English now. They are comfortable with the language they speak. They are comfortable with having interpreters available if they should need them. We're not forcing people to change simply to suit our desires. If a patient is interested in cochlear implants, we're absolutely going to do everything we can to get them for them. But if the patient is not interested in cochlear implants, we are dropping it. Speech. If somebody has difficulty with speech, we're going to allow them extra time to get that speech out. We're going to use picture boards, encourage speech therapy. Speech therapists are phenomenal. They come up with the picture boards. They come up with they can get the equipment that Stephen Hawking had that allowed him to speak via the computer. There's all sorts of different ways that we can get speech. We can get artificial larynxes for people with laryngectomies who've had laryngeal cancer. They can get the little thing that touches their neck so that they can continue to speak. So get speech therapy involved if somebody has a speech type issue. People with touch. We're going to start again with children. Educate them on that spinal cord injury prevention. Do not dive into a shallow pool, even if you've done it a million times and you know you're safe. There is always that one time, and it's never something that you expect to happen to you. Proper foot care if they have that diabetic neuropathy. They're going to be wearing shoes at all times. They're going to do daily foot checks. Use a mirror to see the parts of the feet you can't see because you can develop painless ulcers. And keeping good glycemic control. The olfactory and taste. Make sure we're brushing those teeth. You guys know how obsessed I am with good oral hygiene. It can prevent so many other issues. Encouraging helmet use. Stop smoking. People who stop smoking will regain that ability to taste. My father was a smoker. The entire time he was smoking, he loved things like Spam and Vienna sausages and all that kind of stuff. And the minute he quit smoking and got that taste back, he said they were absolutely disgusting and he had no idea what he was doing. It was because those taste buds were dulled. Seasonings to enhance flavor. Salt is a great seasoning if you do not have cardiac or kidney issues. If you have cardiac issues, only using things like Mrs. Dash that are a potassium based um, seasoning are great. If you are taking a medication that helps you retain potassium or you have kidney failure, do not use Mrs. Dash. It has high potassium. But there's so many seasonings that are around besides just salt, pepper, and Mrs. Dash. There's cumin, there's rosemary, there's thyme, all sorts of different flavorings that we can use to get better flavor into that food. And then we want to make sure anybody who has any touch, taste or smell issues specifically has working smoke and carbon monoxide detectors. If they cannot smell the smoke or smell the additive put into natural gas, they are at high risk of death from those events. So make sure we're checking those smoke and carbon monoxide detectors every month. So the basic summary is alterations in senses can significantly impact overall well-being. Common vision and hearing issues are refractive errors, cataracts, glaucoma, diabetic retinopathy, and there's a bunch of different types of hearing loss. Just remember that with hearing loss, it can be sensory neural, which is all the nerves are having issues communicating with each other, or it can be conductive, which means there's something blocking the way. Taste and smell disorders are commonly together. Those are going to increase risk of death from fire or carbon monoxide poisoning. It's really important that we drill this into people's heads. Age, medication, neurocognitive disorders can increase the risk for these issues. We need to do a full physical exam, neurological assessment, and then there are specific diagnostic tests that can be ordered by the provider. And nurses do a huge part when it comes to education, support, and getting that safety awareness for sensory impairment.